Buenas noches con todos. Muchas gracias por conectarse a nuestra sesión número 3 del curso internacional multidisciplinario en cáncer de mama que la Sociedad Peruana de Mastología ha organizado y que en un esfuerzo que gracias a la industria farmacéutica, en este caso laboratorios AOT, podemos hacer que llegue hasta ustedes. Mi nombre es Franco Doimi, yo soy anatomopatólogo, soy patólogo oncólogo y tengo a cargo esta sesión de inteligencia artificial en el cáncer de mama. Esta noche tenemos a 3 invitados. Primero vamos a tener una charla pregrabada, que es la charla del doctor Vicente Peg. Él es el jefe de la unidad de patología mamaria en el Hospital Valdebrón de Barcelona. Trabaja en el departamento de anatomía patológica, es anatomopatólogo, y ellos están innovando, están creando una red muy interesante de centros de laboratorios de anatomía patológica con patología digital, lo cual soluciona y permite pues, que las imágenes sean consultadas entre diferentes patólogos. Posteriormente vamos a tener al doctor Anant Madabhushi, quien es un ingeniero biomédico con varias especialidades y subespecialidades y PhD. Le he dicho que por favor él haga algo que me ayude un poco en la introducción, porque tiene una vasta experiencia y un currículo muy amplio, que va a hablar también de los usos de la inteligencia artificial y de las imágenes biomédicas en el diagnóstico de cáncer de mama. Y finalmente vamos a tener una discusión con el doctor Madabhushi, y también hemos invitado al doctor Mauricio León, que es médico cirujano, es cirujano oncólogo y oncólogo de mamas, piel y tumores de partes blandas, es director del Centro Detector del Cáncer, es muy conocido por todos nosotros y también trabaja en la clínica Ricardo Palma, ex INEN, donde también tuve el gusto de conocer a él y a su papá, que es el doctor León, recordado por todos nosotros. Entonces vamos a tener después una discusión. Mauricio tiene una plataforma de inteligencia artificial que se llama Mauchis y ya nos va a contar acerca de eso de repente al final de la sesión. Entonces, sin hacerla muy larga, quiero darle pase a Flor para que nos pueda transmitir la charla del doctor Vicente Peg, que es de anatomía patológica y las imágenes digitalizadas en anatomía patológica. Adelante y muchas gracias.
Listo, doctora, gracias.
Hola a todos, soy Vicente Peg, patólogo del Hospital Valdebrón de Barcelona, especialista en patología mamaria. En la actualidad soy también el responsable del grupo de trabajo de patología mamaria de la Sociedad Española de Anatomía Patológica. Y antes de empezar esta charla, me gustaría agradecer sinceramente a los organizadores de este evento su invitación y la oportunidad de poder compartir con ustedes esta presentación. En las siguientes diapositivas intentaré plasmar o mostrar el papel que tiene en la actualidad y el que tendrá en un futuro la patología digital en el cáncer de mama. Estos son mis conflictos de interés. Y para empezar me gustaría mostrar un poco la evolución que está teniendo el diagnóstico del cáncer de mama en los laboratorios de anatomía patológica. En la mayoría de los centros sigue siendo una herramienta fundamental el microscopio convencional de campo claro, pero con el paso del tiempo fuimos viendo cómo se introducían nuevas técnicas como la inmunohistoquímica, ya presente en la práctica totalidad de los centros de anatomía patológica y que no solo permitían un diagnóstico más preciso, sino que además nos dan la posibilidad de determinar una serie de biomarcadores, como es el caso del ER2 que aparece en la imagen, y en algunos casos donde resultaba equívoca la tinción inmunohistoquímica se podía proceder a otros estudios más complejos como la hibridación in situ, en este caso con hibridación in situ fluorescente. En los últimos años hemos visto cómo nuevas tecnologías de alta capacidad analítica se han ido introduciendo. Es cierto que en el cáncer de mama todavía no están implementadas en el día a día, pero como sí sucede en otros tumores sólidos, como es fundamentalmente el cáncer de pulmón, pero en cualquier caso, técnicas de NGS se están abriendo paso en el manejo de estas pacientes. Y finalmente, aunque también lleva años en el mercado, la patología digital está ganando también poco a poco su sitio dentro de los departamentos de anatomía patológica. Y será sobre este último punto en el que centraré mi presentación. Si nos ceñimos a lo que actualmente está recomendado por las principales guías del diagnóstico del cáncer de mama, desde un punto de vista anatomopatológico, tenemos como tres grandes pilares. Por un lado, la determinación de características morfológicas, clínico-patológicas con la hematoxetina eosina, como puede ser el grado histológico, el tipo de tumor, la extensión, etcétera. Y luego la determinación de dos biomarcadores fundamentales, los receptores hormonales y el HER2, y es así como vienen recomendadas por las guías de ASCO, como les decía. Finalmente, he puesto el Ki67, que si bien sigue siendo un marcador conflictivo o en entredicho, si se debe considerar un biomarcador como tal, aunque la mayoría de las guías no recomiendan que sea utilizado en este sentido para la toma de decisiones terapéuticas, pero es cierto que en muchos centros se emplea ya que permite categorizar o tener una mejor impresión del tumor al que nos enfrentamos. Pues bien, como digo, estos son los pilares en los que se basa actualmente el diagnóstico convencional de un cáncer de mama y el que guía el tratamiento, pero no por ello carecen de una serie de limitaciones. Es famoso este artículo ya del año 2015, algo antiguo, pero que tuvo mucho revuelo y mucha repercusión mediática en los Estados Unidos de América, ya que ponía un poco en entredicho la capacidad o mejor dicho, la concordancia en el diagnóstico morfológico, en el diagnóstico patológico de las muestras con cáncer de mama. En general, se vio que la concordancia en líneas generales era de un 75% respecto a un panel de expertos, lo que, si bien es un porcentaje alto, llama la atención que hay una cuarta parte de los casos donde la concordancia no fue tal y por lo tanto se dieron resultados distintos, y que la mayor tasa de discordancias, de discrepancias, fueron en los carcinomas ductal in situ, diferenciarlos de la atipia de un grado menor. Es cierto que este artículo tenía muchas limitaciones que no voy a pasar a detallar, pero en cualquier caso no reflejaban la realidad del día a día, en el sentido de que no se podían realizar más técnicas, no se podía consultar el caso y simplemente era la valoración de una única preparación histológica. Y por otro lado, el acuerdo de las lesiones malignas frente a las no malignas fue francamente alto. Si nos centramos ya en otra de los pilares que mencioné anteriormente para el diagnóstico del cáncer de mama, como es el HER2, también es algo de sobras conocido la discordancia y la discrepancia que puede existir entre distintos centros. Si nos fijamos en una evolución general de cómo ha variado las positividades o las discordancias, mejor dicho, de HER2 en una serie de 12 años de seguimiento con control central, con determinación local del HER2, ya pueden ver cerca de 1.600 pacientes, si bien las tasas de discordancia han bajado drásticamente, de algo más de un 50% a alrededor del 8% actualmente, sigue habiendo un porcentaje no desdeñable de casos que no concuerdan según el centro que los determina. Por otro lado, les he comentado el problema del Ki67. Insisto que no es un biomarcador reconocido como tal. Es cierto que en las últimas guías del 2021 del Grupo Internacional de Ki67 se propone la posibilidad de evitar realizar plataformas genómicas si el Ki67 está por debajo del 5% o por encima de un 30%, si bien es necesario que los patólogos hayan tenido un entrenamiento específico para la valoración del Ki67 y se haga según unas guías recomendadas. Como les digo, sin embargo, es un anticuerpo, es una técnica que se emplea y, entre otros motivos, porque permite diferenciar los subtipos intrínsecos de cáncer de mama. Evidentemente, en la práctica diaria no podemos disponer de plataformas de expresión génica para llegar a la misma clasificación que propuso Chuck Perú en el año 2000, y por lo tanto la aproximación de San Galen es el método más sencillo que tenemos los patólogos de mama para estimar o intentar clasificar y dar el subtipo histológico, el subtipo intrínseco del cáncer de mama. Pues bien, recordemos que el Ki67 es uno de los parámetros que se tiene en cuenta. Aquí lo pueden ver, si bien el punto de corte es variable y está también en entredicho, se consideró inicialmente un 14%, después se abrió la puerta a un 20% e incluso a que cada centro valorase su propio punto de corte. Se sigue considerando como el mejor el 14%, aunque es un punto de corte estadístico y en la práctica diaria la mayoría optan por un 20%. Como les digo, en la última valoración del grupo de trabajo de cáncer de Ki67, el grupo internacional de Ki67, mencionan esta posibilidad que en función de este valor podamos evitar la determinación, la realización de plataformas genómicas que tienen un alto coste y que por lo tanto no están disponibles para todo el mundo. A su vez, otro de los temas que comentan es la posibilidad de abrirle las puertas a las valoraciones automáticas, digitales, mediante inteligencia artificial de este biomarcador para intentar mejorar la reproducibilidad entre las mismas. Pues bien, en las anteriores diapositivas les he mostrado, como les digo al principio, en qué se basa el diagnóstico convencional del cáncer de mama y sus biomarcadores, algunas limitaciones que tienen estos, fundamentalmente de reproducibilidad, y aquí es donde daríamos paso a quizá que una de las posibles soluciones venga de la mano de la inteligencia artificial en la patología digital. Y esta posibilidad se abrió claramente un camino cuando la FDA por primera vez aprobó el uso del Host-Light Imaging, de la digitalización completa de la imagen para el diagnóstico histológico. Una de las primeras dudas que pueden venirnos al oír este tipo de valoraciones o de decisiones de la FDA estadounidense es cómo de concordante, cómo de reproducible es el diagnóstico digital frente al diagnóstico convencional. A modo de ejemplo, este artículo publicado el año pasado, donde miran las concordancias y las discordancias entre el diagnóstico microscópico convencional frente al digital. Fíjense que se trata de un metaanálisis amplio de 25 estudios que recogen a más de 10.000 casos y que las discordancias no fueron muy altas, 546, que puede parecer un número alto, pero dentro de la gran cantidad de casos no lo están. Y esto se debe fundamentalmente, de nuevo, a pequeños criterios más subjetivos, como el grado de atipia citológica, la diferencia entre displasia y malignidad, casos complejos, una cuarta parte de las discordancias se debían a casos difíciles de interpretación e incluso había un 16% que no es que fuese una discordancia, sino que el problema se centraba en la escasa representación. En cualquier caso, la conclusión fue que la patología digital, el diagnóstico sobre imagen digital es muy concordante con el diagnóstico en preparación convencional. Aquí quedan detalladas con algo más de precisión dónde se centraban estas discordancias que les he comentado. Otro de los puntos que he comentado anteriormente era la reproducibilidad de las lesiones de las preparaciones histológicas del diagnóstico morfológico entre patólogos. En este caso, mediante una técnica de inteligencia, un algoritmo de inteligencia artificial creado ad hoc para este estudio por los investigadores, analizan 240 biopsias de mama y fíjense que la presentación o la clasificación es similar al artículo del 2015 que les he presentado al principio de la presentación. Infiltrante frente a lesiones benignas, atipia o lesión intraductal frente a lesión benigna y por último, la que pareció más complicada de concordar en el primer artículo, la atipia de menor grado versus el carcinoma ductal in situ. Se comparó, como pueden ver, los resultados de la inteligencia artificial frente a 87 patólogos especializados en patología mamaria. Para este algoritmo le enseñaron a la máquina a diferenciar la distribución del tejido, así como las características de las estructuras. Aquí pueden ver cómo extrae, por ejemplo, la capa ductal de las capas más internas y en cualquier caso presentó unas concordancias respecto a los patólogos realmente altas. Para diferenciar entre carcinomas infiltrantes frente a lesiones no infiltrantes, la precisión fue prácticamente la misma. Es cierto que tuvo peor capacidad para diferenciar los casos de atipia o de lesión intraductal frente a la benigna, pero sin embargo, por el otro lado, en los casos difíciles y más complejos de atipia frente a lesión intraductal neoplásica, aquellos donde más discordancias había habido en el artículo inicial que les he mostrado, este algoritmo permitió unas tasas de una precisión mayor que con los patólogos, como pueden ver en esta gráfica. Los algoritmos de inteligencia artificial han ido más allá y no solo son capaces de diagnosticar las lesiones o los patrones fundamentales de la hematoxilina eosina, sino que también mediante este mismo análisis de la hematoxilina eosina son capaces de aportar parámetros extra pronósticos o predictivos, como en este caso analizando exclusivamente las características nucleares del tumor predicen la respuesta al tratamiento neoadyuvante. En su estudio demostraron cómo, además de la multifocalidad y la multicentricidad, la intensidad nuclear, así como una correlación del nivel de grises respecto a la matriz analizados mediante el algoritmo de inteligencia artificial, se asociaban de forma independiente con la probabilidad de alcanzar una respuesta patológica completa. Fíjense que el modelo desarrollado por estos investigadores clasificó correctamente cerca del 80% de los casos, un 62% de respuestas patológicas parciales y un 90% de respuestas patológicas completas. Si nos centramos ya en los biomarcadores, el HER2 posiblemente sea uno de los más destacados por todas las connotaciones que tiene, por la importancia de tener un fármaco específico asociado a él y con una respuesta tremendamente beneficiosa para las pacientes. En este estudio pueden ver cómo, utilizando algoritmos de inteligencia artificial, el sistema es capaz de reconocer la tinción de membrana, los distintos patrones, intensidades, y aquí pueden ver cómo, comparando la tinción inmunohistoquímica convencional manual frente a la digital, tenemos una concordancia extremadamente alta de un 92% si estamos empleando el ERCEP-test, global del 92%, 92,4% si es ERCEP-test y 91,8% si es el Pathway 4B5 de ventana, con unas especificidades y sensibilidades en el ISH extremadamente altas y un índice kappa de 0,86, es decir, un índice de concordancia entre técnicas muy alto. Otra de las preguntas que puede surgir es si esta valoración del biomarcador del ER2 por inteligencia artificial supone, aparte de una mayor reproducibilidad de la determinación, algún otro beneficio para la paciente. En este caso, se realizó también un algoritmo para el análisis del ER2 en un estudio fase 1 de trastuzumab deruxtecan en pacientes ER2 positivas y donde se valoró si este algoritmo podía servir como predictor del beneficio clínico del tratamiento. Esta es una imagen con muy pocos aumentos, pero donde pueden ver que cómo el algoritmo es capaz de reconocer las diferentes áreas. En rojo identifica claramente las zonas tumorales, las zonas epiteliales infiltrantes, en naranja el estroma tumoral y en oscuro, en negro, las zonas de necrosis que quedan excluidas del análisis final del ER2. Aquí tienen un ejemplo donde pueden ver cómo reconoce con mayor detalle la célula neoplásica y cómo es capaz de fijarse o identificar la zona de tinción, que es de membrana, Los colores tienen aquí la leyenda: naranja cuando la tinción de ER2 es parcial. Los fibroblastos también los reconoce de forma diferente, así como los linfocitos y los macrófagos. Reconoce los distintos tipos celulares, valora el ER2 solo en aquellos donde debe tenerse en cuenta, en este caso el epitelio neoplásico, y finalmente obtiene el score final y la valoración del biomarcador. Si miramos y comparamos los resultados de ambas valoraciones, vemos que en este estudio, evidentemente tuvo que ser dos positivos, cerca de un 82% fueron considerados como tal por la valoración manual, frente a un 86% de la valoración del algoritmo. Es decir, había cerca de un 4% más de pacientes consideradas como ER2 positivas por el algoritmo. Si bien el hazard ratio fue similar en ambos casos, las tasas de respuesta fueron algo superiores en aquellas pacientes que habían sido consideradas como ER2 positivas por el algoritmo. Dicho de otra manera, el algoritmo detectó más pacientes candidatas al tratamiento que además se beneficiaron más. Por último, al modo de resumen de lo que es capaz de realizar actualmente la inteligencia artificial, les pongo esta tabla grande que prácticamente no cabe en la diapositiva, de un artículo relativamente reciente donde intentan suplir las carencias o la dificultad que supone realizar una plataforma genómica, en este caso el Prosigna, a las pacientes con cáncer de mama, y mediante un algoritmo de inteligencia artificial que solo estudia y evalúa la tinción de hematoxilina y eosina, miran la tasa de la capacidad, mejor dicho, de predecir la positividad de estrógenos, el grado histológico, así como el subtipo intrínseco del tumor y finalmente el ROR, el Risk of Recurrence, que es el resultado que da el análisis de Prosigna. Las conclusiones son que estas pacientes, mediante el estudio por inteligencia artificial, tenían una precisión del 82% para definir el grado del tumor, bajo, intermedio, frente a alto grado, de un 84% para predecir la expresión de receptores de estrógenos, para el subtipo basal frente al no basal un 77% de precisión, y para el subtipo histológico un 94% de capacidad de diferenciar el ductal o tipo no especial frente al lobulillar. En cuanto al riesgo de recidiva, el resultado que proporciona la plataforma, el Prosigna, alto versus bajo o intermedio, fue de un 75%. Es decir, permitía o puede permitir evitar el uso de plataformas con un coste muy elevado en una población alta de pacientes. Y finalmente, déjenme que les presente, a modo de ejemplo, un programa, en este caso desarrollado por Roche, para la valoración del ER2 directamente por parte del patólogo. Aquí tienen algunas capturas de pantalla de cómo funciona la aplicación. Fíjense, de todas formas, y perdonen que recalque que su uso es RUO en la actualidad, Research Use Only. No se debe utilizar por sí sola para la toma de decisiones o valoraciones finales del biomarcador. Tienen que ser una herramienta de ayuda. En cualquier caso, fíjense el área que determina o que soy capaz de analizar en un periodo de tiempo extremadamente corto, porque la preparación ya ha sido previamente analizada. Una vez escaneada, el algoritmo la analiza directamente, de tal forma que yo rápidamente tengo los resultados de las zonas que voy a seleccionar. Está en mi región de interés número 1. Fíjense que tengo más de 1000 células contadas. Este es un caso sencillo con un valor de 0, pero el algoritmo es capaz de reconocer la intensidad y el tipo de tinción, si es completa o parcial, de la membrana. Yo pude ir seleccionando de distintas zonas y en un periodo de tiempo extremadamente corto obtener los resultados, porque, como digo, ya ha sido analizado previamente. Además de eso, insisto, con el análisis previo que ha realizado, en el momento que yo entro a la preparación, si quiero, puedo tener un mapa caliente donde me indica las zonas que han resultado más o menos positivas para el biomarcador. Y fíjense de nuevo la capacidad que tiene para excluir las zonas donde no hay tumor. Este algoritmo cuenta además con la posibilidad de realizar la cuantificación de la hibridación in situ. En este caso trabajamos con hibridación in situ de campo claro, el dual-ish de ventana, con una sonda cromogénica y otra de plata. De nuevo, como el análisis ya ha sido realizado con anterioridad, el algoritmo funciona extremadamente rápido cuando nosotros seleccionamos el área de interés, que puede ser manual, dibujándola nosotros, o bien automática. Cuando llegamos a una zona en concreto, le decimos al algoritmo que seleccione la zona de interés. Llama la atención quizás un poco que las células están separadas porque el sistema busca aquellas que son claramente representativas, con contornos bien definidos y donde se ven bien las señales. En cualquier caso, si nosotros tenemos cualquier duda o discrepamos de alguna de las valoraciones que ha realizado el algoritmo, aquí tenemos el contaje de las 20 células que recomiendan actualmente las guías de ASCO-CAP que debemos realizar para la cuantificación del ISH de ER2. Y como digo, si hay alguna célula que no me convence o que no me interesa, por el motivo que sea, puedo seleccionarla, me indicará a qué posición de las 20 corresponde, puedo eliminarla y seleccionar yo manualmente una alternativa. Termino con dos diapositivas para que vean el impacto que está teniendo la patología digital, en este caso en nuestro centro. De hecho, con el objetivo de mejorar en general el diagnóstico para el paciente, se ha propuesto y se está llevando a cabo una digitalización masiva de una serie de hospitales que forman parte de la red de hospitales del ICS, del Instituto Catalán de la Salud, de la Comunidad Autónoma de Cataluña en España. El objetivo es trabajar en red, mejorar los flujos de trabajo y en general mejorar la productividad y a fin de cuentas el diagnóstico para las pacientes. Algunos números para que vean lo que supone este proyecto. Va a involucrar a cerca de 170 patólogos distintos que trabajamos en 7 centros. Supone adquirir 21 escáneres, 37 estaciones de macropad para realizar trabajo de macroscopía, de inclusión de muestras, teniendo en cuenta que una preparación histológica pesa aproximadamente 1,5 gigabytes, está pendiente y que tenemos un cálculo aproximado de 1 millón de preparaciones al año. Esto fue lo que se obtuvo en el año 2019. Se ha calculado que estaremos rondando los 2 petabytes anuales de memoria de almacenamiento que necesitamos. Esto tiene un coste económico extremadamente elevado, como pueden ver, pero además de digitalizar las preparaciones, nos va a permitir ir desarrollando en paralelo herramientas de inteligencia artificial, algunas similares a las que les he mostrado anteriormente, que permitan fundamentalmente hacer un filtro y un apoyo, una ayuda para el patólogo. Quizás cuando esta red se termine de implantar, que es inminente, se convierta en la red de patología digital más grande del mundo. Con esto me gustaría concluir diciendo que el diagnóstico patológico va a afrontar en los próximos años un nuevo reto con la patología digital y con la integración de nuevos algoritmos basados en inteligencia artificial, que si bien estos están inicialmente basados o enfocados a la interpretación de biomarcadores con el objetivo de hacerlos más reproducibles y accesibles a cualquier centro, servirá también sin duda para hacer de filtro con el diagnóstico de muestras de hematoxilina eosina, permitiendo seleccionar de inicio aquellos casos que requieran un mayor trabajo o mayor dedicación por parte del patólogo por su complejidad. Y finalmente, que es una oportunidad para todos nosotros para adaptarnos y explotar el gran potencial que puede suponer la inteligencia artificial y la patología digital en nuestro día a día y siempre en beneficio del paciente. Muchas gracias por su atención.
Bueno, muchísimas gracias, Vicente. Vicente está ahorita en el Congreso de Anatomía Patológica de España, entonces nos tuvo la gentileza de enviarnos la charla pregrabada. Entonces, si hubiera alguna pregunta, por favor que si la podrían ir mandando a través de la plataforma. Y como pueden ver, pues definitivamente para nosotros los patólogos el camino el cual debemos seguir es el de la patología digital. Pero definitivamente para llegar a un buen camino y tener patología digital, tenemos que pensar en que todos nuestros procesos previos a la digitalización sean óptimos. Tenemos que tener buenos cortes, buena fijación de tejido e información adecuada clínica para poder hacer lo que ya están haciendo en España en Valdebrón. Bueno, nuestra siguiente presentación es del doctor Anant Madabhushi. El doctor Anant Madabhushi es profesor del Instituto O'Donnell de Ingeniería Biomédica, es ingeniero biomédico, tiene, tiene un master degree y un PhD en inteligencia artificial y en análisis de imágenes. Si bien tiene una amplia experiencia y un currículum muy extenso, él va a enfocarse básicamente en la aplicación de inteligencia artificial en cáncer de mama. Para nosotros es un gran honor tener al doctor Madabhushi aquí y le voy dando el pase para que nos dé su charla. Después vamos a tener una discusión de repente o vamos a responder algunas preguntas que ya lo vamos a hacer netamente en inglés y pueden acceder al sistema de traducción que se encuentra disponible. Así que, bueno, please, Dr. Madabhushi, welcome to this important course of multidisciplinary course of mastology. Go ahead, please.
Thank you very much, Franco. My Spanish is a little rusty, so I think I caught about 5% of that, but I thank you for what I think was a kind introduction. Just want to thank Dr. Carlos Castaneda for inviting me to do this presentation. And, I know we're in a crazy time right now, but hopefully at some point in the future, things will return to some semblance of normalcy, and hopefully we'll be able to do this in person. I've been to Peru back about 5 years ago. Would love to go back. Really loved the country and enjoyed my stay in Lima. So I want to talk today about the work that's happening in our group at Case Western Reserve University in Cleveland, Ohio, and also through my appointment at the Lewis Stokes Cleveland Veterans Administration Medical Center. I want to talk about the work that our group is doing around artificial intelligence and precision oncology. And today, even though our group is working on a number of different cancers, including lung, prostate, rectal, head and neck, oropharyngeal cancers, I want to specifically focus on the work that we're doing around breast cancer. There is a saying that if you don't have any conflict, there is no interest. So I'm glad to report that I do have some conflict of interest disclosures to report. And we are working with pharmaceutical companies as well as other companies to help translate some of the technologies and the discoveries that we're making in our group out into clinical practice. If any of what I present today is somewhat interesting, then please consider giving me a follow on social media. That's my Twitter handle. I often post on issues or matters relating to artificial intelligence, precision medicine, digital pathology. So if you are on Twitter, that's my Twitter handle. All right, so I want to set the stage a little bit and talk about the problem of cancer, and in particular, talk about why there really is a need for artificial intelligence technologies to try to address some of the issues around the overtreatment and the overdiagnosis of a number of different cancers. So firstly, some statistics. And the first time that I remember seeing these statistics, I was shocked. I was shocked when I heard that up to 40% of the adult population in the United States would be diagnosed with some form of cancer in their lifetime. Basically, 1 in 2 men and 1 in 3 women in the United States would be diagnosed with some form of cancer. Now that's a staggering statistic. 40% of the adult population in the United States being diagnosed with some form of cancer. But when you actually look at the mortality on account of cancer, there is a big disconnect between the number of people dying because of cancer annually versus the number of people being diagnosed with cancer on an annual basis. And particularly when you look at the fact that 40% of the adult population will be diagnosed with some form of cancer, and you look at the fact that the total mortality on account of cancer in the US is about 600,000, there clearly is a disconnect. So the question then is, well, what is the reason for this disconnect? Why, even though 600,000 deaths is of course a large number, there clearly is a discrepancy between that number and a 40% diagnostic incidence rate. Now, we know that imaging has become more routine, more prevalent for early screening, early detection, early diagnosis of a number of diseases like cancer. We know lung cancer screening using CT scans saves lives. It helps in early detection of the disease. Similarly, in the context of breast cancer, we have better biomarkers at our disposal, such as circulating DNA. We have, in the context of prostate cancer, prostate-specific antigen, even though many will argue it's not a very good biomarker. But nonetheless, we are using biomarkers today in a more aggressive way for early detection of disease. And we know that early detection of cancers results in better prognosis and better outcome. We also have better therapies. We have things like immunotherapy that have changed the landscape of how a number of cancers are treated today. But if we're completely honest, we have to recognize that at least one of the reasons for the disconnect between the number of people dying because of cancer versus the diagnostic rate of cancer is because of the fact that we are overdiagnosing and overtreating a large number of cancers today. Prostate cancer is a classic case in point where 1 in 7 men in the United States will be diagnosed with prostate cancer in his lifetime, but only 1 in 40 will actually die on account of it. And so the question is, well, what is the issue? Why is there an issue around overdiagnosis and overtreatment? Isn't that a good thing? The challenge with overdiagnosis and overtreatment is that many cancers which are identified at an early stage don't actually need aggressive treatment. A number of cancers detected in early stage can actually avoid more aggressive therapies like chemotherapy, for instance. In the context of prostate cancer, we end up treating a lot of men with relatively indolent disease, that is, disease that is not aggressive. We end up treating them with radiotherapy, or we end up treating them with surgery. And these are radical therapies, these are interventional, and these actually cause harm to the patient. A number of patients with prostate cancer or treated with radiation therapy will ultimately end up developing rectal cancer. We know that radical prostatectomy or surgical resection of the prostate does not have a 0% likelihood of mortality. In fact, there is a certain risk of bleeding and complications. We know that, of course, there is the issue of incompetence with impotence, in the context of surgical resection of the prostate. So we know that for a number of these more radical therapies, there is a very real issue of patient toxicity. Right? In the United States, however, apart from patient toxicity, there is also the very real issue of financial toxicity. Because we end up overdiagnosing and overtreating a number of patients, and because of the way the healthcare system in the United States works, a number of people in the United States will lose their life savings because of a new cancer diagnosis. Something like 42% of new cancer patients will lose their life savings within a year. 55% will accrue at least $10,000 in debt. And the total cancer cost for Americans in the United States every year is over $80 billion. So there is both the issue of patient-centric toxicity and the issue of financial toxicity that overdiagnosis and overtreatment causes in a number of cancer patients today. And so one of the questions that our group has been asking is, how can we address some of these challenges? What are the things that we can do with artificial intelligence to develop better diagnostic and better prognostic and better predictive tools. Now, diagnostic tools you've seen in the previous talk, where AI tools are being developed for better diagnosis of diseases from pathology images. You saw from the excellent talk that preceded mine, where multiple examples given on the use of AI and image analysis to improve diagnosis by the pathologist. But that's only part of the puzzle, right? Now, 40% of the American population will be diagnosed with cancer. Well, the question is, then what do you do? How do you figure out which cancers are more aggressive or less aggressive? How do you know what treatments to prescribe to these patients? So there's a need for what are called prognostic tools to figure out which patients have more aggressive disease versus less aggressive disease. And there's also a need for more predictive tools, that is, predicting response to treatment. Now, this is particularly important in low and middle income countries. Countries like Peru, countries like India, which is where I'm from, where the issue is also about resources. You don't have the kind of resources that might exist in the United States, where treatment modalities like radiation therapy or chemotherapy are relatively scarce. You don't have sufficient treatment resources for all the cancer patients in the country. So in other words, you have to be able to find intelligent ways to identify those patients who will most benefit from radiation therapy or chemotherapy. And so this is where artificial intelligence can play a big role in helping to identify those patients who truly have the really aggressive disease and therefore will benefit from additional chemotherapy or additional radiation therapy or immunotherapy, versus those patients who have less aggressive disease and might benefit from de-intensification of the therapy, de-escalation, or could avoid some of these more aggressive and radical therapies. And so really what I'm going to talk about today is the utility of AI tools to help address issues not just relating to disease diagnosis, but also disease prognosis and prediction of treatment benefit and therapeutic response. Now, I want to quickly add here that there are tools out there to try to address some of these questions. And certainly in the context of breast cancer, the most popular tool or the most famous tool that's out there is the Oncotype DX assay, which was developed by Genomic Health and today is part of Exact Sciences. So Genomic Health developed this assay, which is a 21 gene expression assay called Oncotype DX, which essentially involved destructive tissue testing, looked at the gene expression profiling from the tissue to figure out, based on the expression of 21 different genes, to essentially obtain a risk score. And the basic idea was from this risk score to figure out which patients had a high risk score. In other words, they had more aggressive disease versus patients who had a lower risk score, in which case they had less aggressive disease. So the question then was, how could we identify those patients who had the high risk score, more aggressive disease, and therefore were going to benefit from adjuvant chemotherapy? That is, chemotherapy that was administered after hormonal therapy and surgery, above and beyond that, which patients needed the chemotherapy. On the other hand, the question was which patients had a low risk score and therefore could avoid the more aggressive therapy and would benefit just from hormonal therapy and surgery alone. So Oncotype DX came along. And over the last 2 decades, it's really become the mainstay in how early stage estrogen receptor positive breast cancers are treated today. And that's been great. There are some problems though. One of the problems is it's an expensive test, which in low middle income countries is a challenge. It's about $4,000 per patient. But beyond that, the test involves destructive testing of the tissue, and it actually is based on a concept of macro dissecting a part of the tumor. Now, one of the things that we know about cancers is that the more heterogeneous cancers are, the more clones that they have, the presence of multiple subclones of the disease, result in more aggressive cancers. So if one is going to be sampling a part of the tumor that doesn't reflect the highest risk profile of that particular cancer, then the associated risk score that is going to be generated is not going to be a true reflection of the actual risk potential of that cancer. And so one of the big issues with gene expression molecular-based tests like Oncotype DX is the fact that they are really subject to this concept of intratumoral heterogeneity and not able to really deal with this issue appropriately, apart from the fact that they're destructive, apart from the fact that they're very expensive and involve physical shipping of the tissue. But it turns out that now with whole slide imaging, which has become extremely popular over the last 2 decades, one can take routine H&E slides, tissue slides, digitize them, and create high resolution images like the one that you see here, which then allows one to be able to start to interrogate these whole slide images with artificial intelligence technologies. One of the things that our group has been doing has been to look at the role of what are called digital biomarkers, a term that I learned from my good friend, Dr. Eduardo Romero, from the Nacional University de Colombia in Bogota. And one of the reasons why you can think of these features as digital biomarkers is because you're not destroying any of the tissue. And yet, we're able to get quantitative metrics, quantitative measurements that describe tumor morphology in a truly unprecedented way, in a way that's not been possible for as long as pathology has been practiced. We've not been able to get this kind of fine, granular, quantitative, and reproducible measurements. The ability to go in, use AI to identify individual cells, to be able to look at the spatial architecture and the spatial distribution of individual cells, the ability to look at textural patterns both within the stroma, within the epithelium. And what AI allows you to do is to be able to convert this H&E slide into very detailed quantitative metrics that can tell us not just about whether or not cancer is present or disease is present, but can tell us much more, can tell us about the aggressiveness potential of the disease, can tell us about what the likelihood of recurrence of the disease is, about treatment response and treatment benefit. And so my journey in this area of computational pathology really began about 18 years ago, 18 or 19 years ago. So I was a biomedical engineering student at the University of Pennsylvania, and I had the good fortune of meeting a couple of pathologists at the University of Pennsylvania, Dr. Michael Feldman and Dr. John Tomaszewski. And there, for the first time, I was introduced to the concept of digital pathology. And when I first looked at a glass slide, I looked at that and said, oh, well, I'm developing AI and machine learning tools for radiology scans like CT and MRI scans. Well, this is nothing. I'm sure I could easily analyze that small little glass slide. And of course, what I didn't realize was that glass slide, when digitized in a whole slide scanner, would go on to become an image that was several gigabytes in size. And along with digitizing and creating such a large image, while there were challenges in how you computationally interrogate and analyze such large images, it also brought with it opportunities because there was such rich data embedded in those images. And the question that Dr. Mike Feldman, Dr. John Tomaszewski essentially got me to start thinking about was, how do you leverage the maximum value from these images beyond what they as pathologists could see from these images from a visual perspective? A few years later, I had the good fortune of meeting Dr. Sridhar Ganesan, a breast oncologist at Rutgers University. And at that time, I was developing algorithms for grading of cancers, breast cancer and prostate cancer, and essentially developing decision support tools for breast and prostate cancer pathologists. But Sridhar, who was an oncologist, essentially looked at what I was doing and said, look, Anant, what you're doing is great, but I think what you really want to be thinking about is, how do you convert this from a decision support tool for the pathologist to a decision support tool for me, an oncologist? Because my concern, my question is, how can I better treat the patient? What can I do with tools that can help me identify which patient will need chemotherapy versus a patient that could actually avoid chemotherapy? And so that was the conception of the idea of the image-based risk score, or IBRIS. And the basic idea was that for any breast cancer patient who was getting a biopsy or getting a mastectomy or a surgical resection or a lumpectomy, you would have H&E slides of the cancer. Those H&E slides could be digitized with a whole slide scanner and then subjected to the machine learning AI algorithms that we called IBRIS. And the reason we called it IBRIS, so the image-based risk score, was because we could then take the patterns on the whole slide images and convert it into a risk score, just like Oncotype DX, where high risk scores could essentially tell you as to which cancers were more aggressive versus the low risk scores, which would be indicative of less aggressive disease. And so the concept of basically creating a digital surrogate for molecular-based tests really began about 12 or 13 years ago. And one of the first things when you think about creating these image-based tests or image-based prognostic tests is, well, how do you go about designing them? Now, there are two broad classes of approaches that you might have heard of today in the context of computational pathology or machine learning in digital pathology. I think one of these approaches was referenced in the previous talk, this concept of deep learning, right? And so deep learning is a very powerful set of methodologies that essentially involve neural networks. And by setting up very complex architectures of these neural networks, the machine learning system is able to learn patterns from input data. So here's an example of something that we published about 6 years ago, where you had a series of images where a pathologist had marked up exactly where the nuclei were on the images. These were then provided to a neural network. The neural network then learned the patterns that best distinguish the nuclei from everything else. And having learned these patterns on new unseen images, the network was able to exactly specifically pinpoint the location of the individual nuclei. So one of the big advantages of these approaches is the fact that they are based on what is called unsupervised feature learning. So essentially, you're really just providing the machine learning network annotated examples. The machine learns from those annotated examples and then is able to push out accurately annotated examples of the precise location of the objects of interest. So this is a powerful approach, and we have been able to make these approaches efficient so that now on relatively sort of commoditized hardware, off-the-shelf hardware, we're able to stand up these networks, which are then able to go in and segment out individual nuclei, hundreds of thousands of nuclei, very, very quickly, very, very efficiently, very accurately. So this has been really quite a game changer in our ability to identify individual cells on these cancer images. One of the other things that these approaches allow for one to do is also to detect the region of interest. And this can be done manually. And of course, you can have a pathologist go in and mark out exactly where the cancer was. And this is a pathologist's annotation, digital annotation of where cancer was on a pathology slide of invasive ductal carcinoma or breast cancer. We trained a network to identify this in an automated way. And sure enough, the network was able to learn. This is a paper that we published a few years ago, where the network was able to learn very, very accurately based on the manual annotations, to the point where the network actually became even better than the human expert. The network was actually able to identify regions that were outside the marked up area of interest. But also, if you look more closely here, the network was also able to accurately identify that there were regions that were relatively benign within the larger marked up region by the pathologist. And the reason simply being that the pathologist didn't have the time to go in and do a very, very careful annotation of the individual benign pockets that were within the larger annotation of the cancer region. And so these tools are really powerful because they provide ways of not just doing cell segmentation, but also region segmentation. In fact, can be used to segment out a variety of different kinds of structures. So here's an example from a paper we published a few years ago, where we showed the utility of these deep learning networks to go in and segment out nuclei, segment out epithelium, stroma, tubules, mitotic figures, series of different categories of histologic primitives could be identified, successfully identified from these images and used to build up these very, very powerful networks. But the question still is, how do we get to the IBRIS score or the risk score? And one of the things I mentioned at the start was digital biomarkers, right? Features, because ultimately we need a series of features or biomarkers that go into a classification model that will then punch out or generate the risk score for who has, the more aggressive versus less aggressive disease. So our group has really focused on what are called interpretable biomarkers, interpretable image biomarkers. And what that means is, rather than solely focusing on a deep learning kind of approach, which is very abstract, very opaque, very black box, our group has taken the approach that we use deep learning only to identify the structures of interest. We use it to separate out the stroma, the epithelium, identify the individual types of cells, the stromal lymphocytes, the tumor infiltrating lymphocytes. Once we've done that, we can use ideas from network theory and graph theory to look at the spatial architecture and the spatial arrangement of the different types of cells. And these different spatial features allow us to start to make predictions. So here's an example of some of the work that we recently presented at the USCAP meeting, where we showed that these features that we had mined from breast cancer images could be used to train machine learning models that could figure out which breast cancer patients were at risk for recurrence. And so what we were able to demonstrate in a cohort of patients from Cleveland, from the ECOG 2197, which is a completed clinical trial from about 3 decades ago, as well as a cohort of patients from India, from the Tata Cancer Center in Mumbai, we were able to demonstrate that these features relating to the spatial arrangement of nuclei, to tubules, to mitotic figures, the combination of all of these in a machine learning model was able to predict recurrence, both for lymph node negative as well as lymph node positive breast cancer patients. So both for lymph node early stage as well as later stage breast cancers, this combination of features was able to predict outcome. We've developed a number of other approaches as well, and I'll just sort of very quickly go through some of these other approaches. This is some of the work we're doing in later stage breast cancer, specifically lymph node positive, ER positive breast cancer, where we take an approach to identify the individual nuclei, looked specifically at nuclear features, and on a pretty large cohort of patients, actually a few thousand patients, we've been able to demonstrate very nicely that across multiple different sites, that there's a clear signal that you can really predict risk of recurrence in these lymph node positive breast cancer patients across multiple different sites, and do it in a way that is independent of a lot of the clinical pathologic factors such as ER, PR, HER2 status, as well as age. One of the other biomarkers we've been looking at is the role of collagen. Now, collagen has been long recognized as a hallmark of tumor biology and tumor outcome. One of the things that we've done is to develop a machine learning approach that identifies tumor nests on H&E images and also segment out collagen fibers on the H&E images. Then by looking at the orientation of the collagen fiber with respect to the tumor nest, we're able to assign a vector to the dominant collagen fiber orientation. And when we looked at patients who had short-term survival versus long-term survival, what we found was that those patients who had short-term survival, the collagen fibers were all very systematically organized. The arrows were all pointing in the same direction. But on the other hand, when you looked at patients who did well, who had long-term survival, the arrows were very haphazardly arranged with respect to each other. And even though that seems counterintuitive, it turns out that collagen, those fibers could be serving as a highway for the cancer cells to hitch a ride to essentially migrate on to different regions from the primary site. And so when you see patients of short-term survival, essentially it might be a reflection that because the highway is so good, it's easier to metastasize. On the other hand, if the highway is really bad, where the collagen fibers are very twisted and tortuous, then it's more difficult to hitch a ride, and therefore the risk of distant spread is reduced because of the architecture of the collagen fibers. And so we were able to demonstrate in an abstract, and we have a paper pending on this topic, that this collagen fiber orientation was associated with risk of recurrence in ER-positive breast cancers in ECOG acron 2197, as well as the cancer genome atlas. So why is this important? Why should we care? And so this is a little bit of my head-to-head comparison between the Oncotype DX and the IBRIS, or the image-based risk score. And so one is the cost of the test. So if you look at the cost of the Oncotype, that's over $4,000. But on an IBRIS test, which only really requires digital images, the internet, and the cost of electricity, that's orders of magnitude lower cost. And that's really important for low middle income countries like Peru, like India, where cost is a really important factor. The other issue is the time. With Oncotype DX, you've got to physically ship the tissue. With IBRIS, essentially it's a digital test, and the test can be run essentially in the order of minutes. You're not destroying any tissue, you're digitizing the specimen, and you have a global footprint with this kind of assay. So in other words, you have an inexpensive, fast, reliable, accessible prognostic breast cancer test that's priceless. For everything else, there's MasterCard. But it's not just IBRIS as a standalone test. IBRIS, actually, we've shown that combining IBRIS with Oncotype DX could significantly improve the performance of Oncotype DX by up to 20%. In other words, by combining IBRIS with Oncotype, we could identify 20% more truly low-risk breast cancer patients who could successfully avoid adjuvant chemotherapy. And it's not just invasive breast cancer. In the context of DCIS, or ductal carcinoma in situ, our group has shown that we can identify with high accuracy which DCIS patients are likely to progress onto invasive ductal carcinoma. And that's really important because, remember, DCIS is stage 0 breast cancer. These are pre-malignant lesions. And one of the big questions here is which of these lesions should we be treating with radiation therapy and which ones can be spared radiation therapy? And so the ability to prognosticate which patients will or will not become invasive ductal carcinoma means that we can now better identify patients who should be treated with radiation therapy after surgery versus not. One of the other questions we've also been pondering is, are there phenotypic differences in the breast cancer appearance between different populations? In a study we just presented at the San Antonio Breast Cancer Meeting, working with our partners at the Tata Cancer Center in Mumbai, we were able to identify that there were unique features that were different between Indian women with breast cancer versus Caucasian American women with breast cancer. Now, why is that important? Now, that's important because it means that the risk models that we develop have to take into account the kind of population that we're working with. And so what we showed in this abstract was that if you take the unique signature identified in breast cancer in South Asian women and create a population-specific risk model, that population-specific risk model is much better at predicting risk of recurrence compared to a population-agnostic model where you don't account for differences between populations. Apart from that, we've also been looking at other motifs such as tumor-infiltrating lymphocytes, something that, of course, we know is extremely important in the context of a number of different cancers. This is work we published a few years ago, where looking at lung cancer patients, we found that the spatial arrangement, the interplay between cancer cells and lymphocytes, was strongly associated with the risk of recurrence in lung cancer patients. We've taken the same approach and recently applied it to triple-negative breast cancer patients. This is work done with Dr. Carlos Castaneda here in Peru, and this work will actually be presented at the ASCO meeting next week in Chicago through a virtual platform. And so what we showed here was this tumor-infiltrating lymphocytic pattern from triple-negative breast cancers was strongly associated with outcome, with prognosis and survival in patients treated both in the United States, in Cleveland, but also with a cohort of patients from Peru. And this data, like I said, will be presented at the ASCO meeting next week. Now, apart from the work I've been talking about on pathology, there's also a lot of information that's latent in radiology, on radiology scans. So our group has also been doing a lot of work looking at subtle patterns, subtle features that could be mined from MRI scans or CT scans. Now, here's an example. This has nothing to do with breast cancer. This actually has to do with brain tumors. And in brain tumors, after patients are treated with chemotherapy and radiation, when they come back to get a follow-up MRI scan, sometimes something shows up on the MRI scan. And the big question for the clinician then is this a recurrence of the cancer, or is this radiation necrosis, which is just an effect of the chemotherapy and the radiation? And though, because it's so difficult to tell visually from an MRI scan, what typically needs to happen is an intervention. So the oncologist needs to go in, do an intervention, do a biopsy, and then figure out whether it's radiation necrosis or is it recurrence of the tumor? And of course, that's interventional. That's $50,000 to do that procedure. And so what our group has developed are new ways of analyzing these scans. And we've essentially found, similar to the collagen fibers, that on a pixel by pixel basis, we can identify the edges. And by looking at the orientation of the edges, we can compute the entropy. So essentially, if you think of entropy, it captures chaos. And so if there's a great deal of disorder in the orientation of those gradients, you're going to see high entropy. If you actually, on the other hand, see a low entropy, it's essentially a reflection of more order, less disorder in the system. So if you look at this particular image here on the left, there's a great deal of entropy, and that essentially reflects a high degree of disorder. On this image on the right, on the other hand, you see that the entropy is very low, reflecting more coherence in the microarchitecture in the organization. So it turns out that the less the entropy, the more the homogeneity, the more likely it is to be radiation necrosis, whereas in those patients with a high degree of entropy, it's more likely that those patients have the cancer recurrence. Now, we've taken this approach and applied it to breast cancers. In work a few years ago, we actually demonstrated that looking at the entropy features of the edges could actually distinguish different subtypes of breast cancer from an MRI scan. We could distinguish ER positive from HER2 positive breast cancers from fibroadenomas. And you can see here clearly, even though the MRI scans are very similar, that the entropy patterns in these different subtypes and fibroadenomas are quite different. We've also shown that the same concept applies to distinguishing molecular subtypes of HER2 positive breast cancer. This was work that we presented at San Antonio, but also published in JAMA Network a couple of years ago, where we showed that HER2 positive breast cancers typically tended to show a great deal more entropy compared to HER2 negative, or rather non-HER2 enriched tumors that had a lower degree of entropy compared to the HER2 enriched tumors. We also have looked at this particular feature for predicting response to neoadjuvant chemotherapy. In a study we published a few years ago, we showed that entropy features both within the tumor but also outside the tumor on MRI scans successfully predicted which patients would have pathologic complete response to neoadjuvant chemotherapy versus patients who would not have pathologic complete response. So in which patients would the cancer completely disappear after neoadjuvant chemotherapy versus patients who would not. And that could be predicted by looking at an MRI scan even before the chemotherapy had been initiated. Even before that had been done, by looking at patterns outside the tumor, we were able to figure out which of these patients were likely to have response versus not. Now, it was so intriguing that the features that were most predictive of response came from outside the tumor. And so in a follow-up study, we were able to get biopsies from the region outside the tumor. And when we looked at the biopsies and digitized them and applied our computational analysis to those biopsies, we found that the entropy features on the MRI were the way they were because of the spatial architecture of the tumor infiltrating lymphocytes. In other words, the particular spatial arrangement, spatial architecture of the lymphocytes was what was driving the particular entropic patterns that we were seeing on the periphery of these tumors outside of the tumor. In the interest of time, I'll skip over this slide here and sort of show just a couple of other examples of interpretable imaging biomarkers. One of the other biomarkers that we've been looking at and discovered recently has been to do with the tortuosity and the twistedness of vessels that are associated with the tumor. Specifically, we found that in patients who tend to not respond to neoadjuvant chemotherapy, the vessels tend to be very convoluted, very twisted. Patients who do respond to chemotherapy have a much smoother, less convoluted, less tortuous vasculature associated with it. And so just based on the twistedness of the vessels that is mathematically described, we're able to predict which patients are likely to have a response to neoadjuvant chemotherapy versus patients who are not likely to have a response. And then more recently, this was from earlier this year, we were able to demonstrate that also in the context of other kinds of treatments, such as CDK4/6 inhibitors, in hormone receptor positive metastatic breast cancer that the radiomics features on CT scans were able to predict survival and response. So with that, let me conclude. So hopefully what I've conveyed in my talk is that computational analytics with routine imaging can help address questions in precision medicine, specifically prognosis and predicting response to therapy. One of the big things about this kind of technology is that it is relatively low cost, and that is really critical for global impact, especially low middle income countries like Peru, like India. One of the important things I'd also like to really hammer home is the interpretability aspect, because you have to think of the end user, you have to think of the clinicians, people like Dr. Castaneda, who've got to make a decision about how to treat patients. And at the end of the day, when you talk about artificial intelligence, you have to realize that clinicians have to make a decision on who to give chemotherapy or not give chemotherapy to, or change the treatment. They are going to not be willing to trust a black box. They are ultimately going to want to understand what is underlying the approach, what is underlying the prediction. So interpretability of the approach becomes really critical to be able to drive clinical adoption. Finally, I just want to thank the amazing group of people that I have the pleasure of working with in my group on a daily basis here in Cleveland. And of course, you always have to thank the funding agencies, the people who put food on the table. Thank you very much for your very kind attention. Thank you.
Thank you very much, Anant. I really enjoy your presentation as breast pathologist. I enjoy a lot, and I have many questions to you. Let me talk in Spanish a little bit, and then we will continue in English. Bueno, muchas gracias a todos por la participación. Ahora vamos a pasar a hacer algunas discusiones y manden sus preguntas por la plataforma. Y yo tengo también algunas preguntas que he venido apuntando en la presentación. I really enjoy your presentation. I am surgical pathologist, and I want to make some questions. Yes, I work in breast cancer, and I always qualify the oncotype tissue that is going to be sent to expert sciences. Sometimes I said, yes, this tissue is going to be high risk. I don't know. I don't understand that if the indication is really correct. I think that thinking in our situation, like low and middle income countries, do you think that artificial intelligence could be used as a previous screening to qualify the tissue that be sent to these platforms like Oncotype or Mama Print or whatever? No.
So I'm going to be controversial. All right, I'm going to be controversial, and I'm going to say that I think more than just serving as a way to qualify or triage cases to be sent to Exact Sciences or Mama Print or any of these tests, I think there's an opportunity to use these tests as a replacement for Oncotype DX, because I think that there is data that is coming out, and that data is showing consistently that there is a lot of power in morphology, right? So, Franco, you know this because you're a surgical pathologist. You look at breast cancers, based on looking at the tumor, looking at the Nottingham grade, looking at the Bloom-Richardson grade, you automatically know, okay, this is a bad tumor versus something that is not, something that's going to be low risk. And what we are doing is essentially using AI to capture fundamentally what you already know, what you already recognize. And so I think that qualification is part of it, but I genuinely think that there is such an opportunity that this could be maybe replacement, maybe even better than some of these other tests, these much more expensive tests. Just one example of a paper that we recently published in Nature Precision Oncology, literally a month ago, in the context of prostate cancer. In prostate cancer, there's still a question of predicting recurrence. Which patients will have metastasis, which patients will have biochemical recurrence. And in that paper, we showed that by looking at H&E slides alone and by using AI to pick patterns from pathology images of the prostate, we could do better compared to the Decipher test, which is the Oncotype DX equivalent test for prostate cancer. That's a $3,000 test that's in the NCCN guidelines. We showed in 173 patients head-to-head that if you take the AI, you combine it with Gleason score and you combine it with PSA, you could do better than a $3,000 test. So I genuinely think that not only can we do triaging or screening, we could potentially obviate or even replace Oncotype in many cases.
It's wonderful. So I think one more question. So if we try to improve this imaging analysis now, as pathologists, as managers of many laboratories, our job is to improve the quality of our slides. I think that is very important to improve the fixation and the quality of the slides. If we don't have high quality slides, we cannot try to think to go to intelligence in artificial intelligence or to digital images. So what we have to do is to prepare our country to this new situation, no? So if we don't have good quality of images, we cannot do in artificial intelligence, no?
Yeah, you're absolutely right. And so I think that part of it is you need to be able to do the basics to be able to create the slides. So that's sort of a given. But even there, once the slide has been created and the slide gets digitized, even there, I think there's an opportunity with AI. So one of the things that we've developed is a tool called HistoQC. And HistoQC is a digital quality assessment tool. You can look it up on the web. It's freely available. Essentially, what we recognized a few years ago was that slides are being created, they're getting imaged, but there's so many problematic slides. So how do you know whether your slide is even diagnostically worthy? Is it good enough for an AI algorithm? So we developed this tool called HistoQC that would provide a quality assessment score to the digital pathology image, and to tell you basically whether this was an image that was diagnostically worthy, whether it was worthy for computational analysis. And so by having checks like that, where AI can now tell you even before the interpretation happens, it can tell you, hey, Franco, this image, don't even look at it because it got flagged by HistoQC as not being worthy of your time. And then you can send a message back to the tech saying, this image, this slide that you created was not appropriate. You need to cut the slide again, or you need to recreate the slide. So I think that as we start to think about the quality, the quality piece is extremely critical, and we have to be able to address that, not just for visual diagnostic interpretation, but also for the subsequent computational AI analysis. But there are tools like that. I mean, HistoQC is just one example of a tool, and there are other tools that are being developed as well that I think will really help lay the platform, the assembly line for deployment of the AI tools.
Thank you. It's very interesting. Let's go to the other side of the treatment. No, we have Mauricio León, who is he's breast surgeon, and as you talk, try to assess the pathological response is very important. No, how important is it for you, Mauricio, to know that if a patient have a good response clinical, and how do you think that the importance of the imaging analysis in using artificial intelligence?
Yeah, thank you, Franco, for the question. First I want to say good evening and thank you for the invitation from the Sociedad de Mastología and the excellent presentation of Professor Madabhushi. It's interesting here an engineer show us what is the medicine of the future. Nice to look the relationship between engineer and medicine. Since every time it's more common. Talking about the response of the neoadjuvant treatments, we know that the best prognosis in the breast cancer is classical the axillary nodes. But now, because the most of the patients go to the neoadjuvant treatments, we know that the most important thing or prognosis is the response. What is the amount of the response, for example, of the chemo? If for example, we start with a breast cancer stage clinic 3, this patient received chemo, and after 6 months, it is a complete response. We know that this patient is 99% of cure. You know, now is the most important thing than others. I tell you.
Yes, it's very important. For us, it's very important to have a good technique to qualify the pathologic complete response. Can you tell us, Mauricio, your experience in using Mauchis? Mauchis is an artificial intelligence Peruvian platform that was launched by Mauricio. I think is more directed to the prevention, no? But please share with us your experience using this artificial intelligence platform.
Yeah, thank you, Franco. Mauchis' name is Mauchis is the nickname of my son. He's 14 years old and is the embassy for this platform. Let me introduce Mauchis for everybody. Mauchis is the first artificial intelligence platform in Peru. It was born on October 19, 2020, in relation to the World Day Against Breast Cancer. We use IVM technique. Today, it has almost 10,000 followers and more than 500,000 interactions between the population, general population, and Mauchis. The difference between Mauchis with other platforms is it's used for free and is for the general population, giving cancer prevention advices. As a complement to a medical consultation, never replace them, never replace a medical consultation. I am very happy with this platform that is gaining more and more strength, starting with the breast and cervical cancer that kill 11 women a day, like as you know, in Peru, with totally preventable cancers. No one should die with these diseases. Next month in July, Mauchis will answer questions about almost all types of cancer, including lung, skin, brain, ovarian, gastric, and others, covering the 7 main types of cancer in our country. How we access Mauchis? Through Facebook. You search for Mauchis, you put a like, then you send a message through Facebook Messenger, accept terms and conditions, and you have these platforms active 24/7, 365 days per year to ask what you want about cancer prevention for free. I have a question to Professor Madabhushi. I don't know if this is something similar to Mauchis in other countries, or what do you think about this idea that is a new platform in Peru?
Yeah, thank you, Mauricio. First of all, just congratulations on being entrepreneurial, and you're a breast surgeon, and it's quite remarkable that you found the time to be creative and think of an AI platform that you launched that is doing so well. I was not aware of it. I certainly would like to learn more about it. I think the bottom line, though, is that clearly there's an opportunity for technologies like this, for technologies like I talked about, like the ones that you're developing. I think there's no doubt that we desperately need more technologies like this, and particularly in the context of low and middle income countries, right? Anything where we can do more with less in the context of LMICs, I think is really very, very much needed. So again, I mean, congratulations for all that you've done, and it's amazing. I mean, it's the first time I've heard of a breast surgeon finding the time to go and develop AI tools. So that's really amazing.
Yes,
thank you, Professor Madabhushi.
I think we are going to use the Mauricio's platform to share some images in the future. That's probably. Still working, Mauricio. Thank you. We have some questions from the people of the audience. Congratulations for the presentation. And this is for Professor Madabhushi. They are asking about the cost of the digitalizer and the machine of intelligence, artificial intelligence.
So I mean, I think that cost is a good question, and I put some numbers up there on the slide showing the comparison between Oncotype DX and Ibris and all that. And of course, that those aren't the cost of Oncotype is real. I mean, that's what you would pay for a patient. In terms of Ibris, in terms of the AI, the goal would be that would be significantly lower. I don't know how much lower. It's not, unfortunately, a commercially available test today. Ultimately, that's where we'd like to go. We'd like to create a commercial test, but it's not a commercial test today. But the key piece that the question calls out is the need for the digitization, right? One of the good things is that the digitizers, used to be expensive, about $250,000, but now there are technologies where for $5,000 you can get these digitizers and start to do digitization. I work very closely with a number of collaborators in Bogota, in Colombia. I mentioned one of them, Dr. Eduardo Romero. His group in the Nacional University de Colombia, de Bogota, is developing their own technologies for digitizing the glass slides, and it's very low cost. And so I think that more and more for digital pathology, the cost of the slide scanning is going to keep decreasing. You still have the high-end scanners that can digitize 300 slides overnight, and that's still going to be $200,000. But now you're going to find much lower cost scanners that are not as high throughput, but you can still digitize maybe a few of them at a time, and those are going to be much more affordable.
Yes, I agree with you. We still thinking that we have to get the biggest slide scanner, and that is very expensive. If you want to go to the 100% of the slides in your laboratory, digitalized is very expensive. But you can focus in this. You need you can get a small scanner, about $5,000, and you can start sharing images or using this to take the risk of the patients of breast cancer, no? So it's very interesting. Carlos said that how long is going to be this test available to the routine or to the routine clinical use? how do you expect?
Yeah.
Years?
That's a great question. And I mean, my goal, I mean, I've been working on this now for about 12 or 13 years. And, I think every time somebody asks me, my response is, 18 months, 24 months. And I've been saying that for a long time. And I realized that, this stuff takes time. It takes time because it's not just about developing the technology. It's about really thinking about the whole ecosystem and how do you get something into the ecosystem. Translating stuff is difficult. To some extent, I almost feel as a bioengineer that it's easier to develop the technology than to translate the technology. You can come up with really sophisticated, complex technology, but figuring out how your technology fits into the bigger ecosystem, that's more challenging. So the goal continues to be the same, ultimately, to move the technology out. It has to continue to be validated. We continue to do that. One of the things that we continue to do is validating our approaches on completed clinical trial data sets, continue to grow the evidence, really start to get to higher and higher levels of evidence that this test actually works. And so we're getting close. I mean, I would say that even today, the amount of data that we have showing that this test actually works is significantly more than what we had 2 years ago. But it's not just, like I said, about the technology of validating. It's about how it fits into the ecosystem. So I will say that we're working with a number of commercial partners now to try to move this technology out. My hope is that in sort of the next 2 to 3 years, we're able to get some version of this out there, deployed, get this technology being used. And my hope really is that we can start to move this technology first to low middle income countries, because I think that's really where it could really have the big impact in a relatively short time frame.
Yes, thank you very much. Thank you for your sensibility. Thinking about the low and mid-income countries, no, because we cannot apply massively genetic platforms, no. I have a last question. This is about the surgical margins. How do you think the digital imaging can help in the study of surgical margins? That is very difficult sometimes when we work with the surgical oncologist. Do you have experience evaluating surgical margins in conservation specimens in breast cancer? Because you show some pictures that the digital analysis show hot areas in different parts, different from the main tumor, no?
Yeah. So so we haven't done that explicitly in the context of breast cancer, but we had a paper that we published recently where we looked at prediction of surgical margins in the context of prostate. And so we were able to use AI from just an MRI scan to be able to predict whether those patients were going to have positive surgical margins, whether they would have adverse pathology on resection. And it was pretty accurate. So we were able to find patterns on an MRI scan that was predictive of the margin status on surgical specimens. It's not perfect, but that could provide part of the answer. Of course, I think it's always a challenge to try to do this. We're trying to do this sort of non-invasively, so it's not going to be perfect. But again, I think, I see ultimately a lot of these tests, as we think about these tests, they're all going to be providing a little bit of information. And ultimately, it's about how you synergize and how do you combine the information. And, one question I get often asked is, this stuff is going to replace the radiologist. This stuff is going to replace the pathologist. It's going to replace the clinician, blah, blah, blah. What people don't understand is that all of this information is only providing the pathologist or the radiologist a part of the answer, a part of the solution. And really what they're doing mentally is taking all that information and connecting it. Even Oncotype DX, right? Oncotype DX is not the definitive answer. It provides a risk score, and that's important. But there's so many other factors that the oncologist is considering when deciding whether to give chemotherapy or not. You're looking at the patient, you're looking at the age, you're looking at ER status, right? Are the lymph nodes positive or not? There's so many different things that are going on before you decide on the course of action. So at the end of the day, I think that all of this information is providing different parts of the puzzle, but ultimately, the end user is going to have to take all of that information and make the best guess or best decision on how to move forward. So with the work we're doing on the positive surgical margins, again, I just see it as a part of the puzzle, ultimately for better patient management.
Okay, thank you very much, Mauricio. I think you have you can explore the possibility to include X-rays, images, pathology images in your AI platform.
Yeah, first is the mega consultations. Maybe the next step is X-rays and pathology. We don't know, and it's a big work. Every day is like it's a lot of questions, and you have to respond every question. And I think in the next months we can do that, something like that. First, we have a lot of questions that need to be responded with a human, not with a, because it's some questions that you cannot replace the mega doctor, and you can only use now in this time for the advices, but in the future I don't know. You can respond every question. I don't know.
Yes, I think your mission right now is to identify the patients who are in high risk, and they have to go right now to a medical oncologist or to
yeah. And the main population from the objective of Mauchis is not the capital, it's not Lima. You have a lot of cities that we don't have medical, no oncology,
yes,
very few surgeons. So it's a lot of questions, it's like legends or myths. It's not like a biopsy is bad for you because your cancer is more aggressive before after a biopsy, or a lot of questions, a lot of things like that, And with Mauchis, you can at least put these things or these myths in the real world,
Yes, it's very interesting. It's very interesting. I enjoy really your this opportunity to share with us Mauchis, and I think I am very happy to be the chairman during this session, but and I think in the future we can send some digital images and make something like a molecular and artificial intelligence and molecular tumor board, something like that. We don't have the correct name right now, but probably in the future we are not only discussing about molecular findings, we will be discussing about the artificial intelligence algorithms or risks evaluating images, So it's very, very interesting. I enjoy this session, and let's Anant, if you have your final words to close the session.
Well, just thank you so much, Franco, for moderating the session. Thank you to Carlos, Dr. Carlos Castaneda, for inviting me. It was a real pleasure coming here and talking about some of these projects that we're working on. And I am really hoping to continue building our strong collaboration with Carlos and extending that further, because I really do think that there's a big opportunity for application of these technologies for moving precision medicine in low middle income countries like India, like Peru. So thrilled to be here to give this talk, but also hoping that this can launch more collaborations between Cleveland and Peru. Thank you.
Okay, sure, we will appreciate it, and we are welcome back you to Peru when things are going to be normal here. Okay, Mauricio, your final words, please.
Thank you very much, Franco. It's very, very nice session. I learned a lot of artificial intelligence. I invited everybody to use this platform. Is Mauchis, M-A-U-C-H-I-S, like sound. And through Facebook Messengers, you can know a little bit about this platform that I hope that help you in prevent of the cancer. Thank you very much for the social society, and thank you, Professor Madabhushi.
Okay, I will close in Spanish. Voy a cerrar la sesión en español. Quiero agradecerles a todos los que nos han escuchado. Ha sido una sesión con muchísima información y les agradecemos en nombre de la Sociedad Peruana de Mastología por acompañarnos esta noche. Muy buenas noches y gracias a todos.